All right, hello everybody, and thank you for attending my lecture. This is our talk today on psychiatric mental health assessment and differential diagnosis. My name is Dr. Ron Dorico. I am an assistant professor in residence in the UNLV School of Nursing. I am the program director of our psychiatric mental health nurse practitioner program. So, as introduction, why are we talking about mental health assessment? We're talking about this because these are disorders and diagnoses that are very, very commonly seen in primary care. Your psychiatric diagnoses are generally based on the results of the patient report, which is going to be your interview, your clinical observation. So, you as the clinician, what you're observing about the patient, labs, imaging studies, things that you may see in primary care or other healthcare fields are going to have a limited to no role in the psychiatric diagnostic area. So it's not something that's going to have a huge place. It's always going to be your observations, and it's going to be what the patient tells you. There's very little physical exam involved, and again, very little in the way of labs or imaging. A psychiatric interview in general and in best practice is much more thorough than a standard primary care interview. We're looking at 60 to 120 minutes, so an hour to an hour and a half for that initial visit. It takes a long time. Sometimes you can look at 2 1-hour sessions. You might have to break it in half. Sometimes you even do 2 hour-and-a-half sessions, depending on the patient's age, the nature of their psychiatric and medical history, and how quickly you can get through the interview. So these are very, very in-depth, detailed interviews. Likewise, the psychiatric objective exam is very detailed. So again, you're not listening to heart and lungs. You're doing very little in the way of physical exam, maybe a small neurological exam, because of course, when you're dealing with psychiatric issues, you're dealing with brain issues essentially. So the neuro exam may play a part in that, but essentially it's almost going to be entirely based on your observation. So the psychiatric interview is the history portion or the subjective portion, and the observations are your objective portion. And that's very important to keep straight as you're entering into the mental health assessment. And these are excellent skills for all clinicians to develop. There's no area of practice where having that eye towards a mental health assessment and examination isn't going to benefit you. All right, so just to start as an overview, we're going to do a deep dive into each of these sections, but I'm just going to kind of go over it just to give you a big picture of what we're looking at. So we're going to kind of approach this as the SOAP format that you'll be learning. So this is subjective, objective, assessment, and plan. So this is universal across different settings. It's commonly understood. It's commonly recognized. You'll see this often. So it's just a good system to learn. So what is the S? So the subjective is comprised of the chief complaint, the history of present illness, the past and pertinent psychiatric history, the past and pertinent medical history, the past and pertinent social history, the family history, and the review of systems. The objective, now the objective exam in a non-psychiatric setting is going to be some sort of physical examination. It'll depend on the setting, and it will depend on the chief complaint. It'll be focused or general. It could be a complete physical. In mental health, this is again all objective. This is observation. This is what you're saying to the patient and what they're telling you back. So the mental status exam consists of the appearance and behavior, mood and affect, speech and thought process, thought content and perceptual abnormalities, and the sensorial, cognitive, and intellectual functioning. Okay, so for assessment, this is the differential diagnoses. Now, as nurses in the undergraduate level, in the pre-licensure level, we learn assessment to equate to the physical exam. When you move to the nurse practitioner level, when you move to the clinician or the provider level, assessment in the SOAP format is actually your diagnoses, okay? This is what you are saying is going on with the patient. At the RN level, this makes sense because it's often mixed. At the RN level, we're not necessarily making medical diagnoses. We're instead saying what we found on our physical exam and what that indicates about the patient. At the clinician or provider level, you're using this assessment for you to really list down your differential diagnoses. Differential diagnoses for mental health disorders are covered in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, commonly called the DSM-5. We also use the ICD-10, which is the International Classification of Diseases system. These go together, and if you look in the DSM-5, all the diagnoses will also have their ICD-10 codes with them. You're basing your assessment on your subjective and objective elements, and this is the same for any setting, honestly. A differential diagnosis comes from your observations there, and we'll get into some more detail. Again, as I mentioned before, things like labs, genetics, brain scans, we're not really leveraging these for diagnostics at present. So this means that I can't put you in an MRI and say, okay, you have bipolar depression. I can't give you an EEG and say you have schizophrenia. There's some very exciting research being done on all of these fronts, and I think those days are ahead of us. There's some preliminary work you can do. There's some people can use quantitative EEGs to really get some good diagnostic information. But at this point, in terms of standard of practice, assessments, which are diagnoses, are based on the subjective and objective components of the interview. Labs are relevant in mental health. So labs, and to a lesser extent, things like imaging, these are very useful in mental health. Specifically, we use labs for things like measuring psychiatric drug levels, to rule in or out medical mimics of certain diagnoses, to monitor for adverse effects of psychiatric medications, such as the antipsychotic medications can cause some pretty severe dyslipidemia and other aspects of metabolic syndrome. So the P in SOAP is the plan. This is where you say, what are you going to do about those assessments that you covered in A? So P follows from A. So this is your diagnostic testing if you're going to do any sort of testing for those psychiatric symptoms. So is there something going on with psychiatric medications? Do you need to rule out a mimic, et cetera? Most of the time, the plan is going to be pharmacological and non-pharmacological treatments. So pharmacological treatments, of course, are going to be the medications we use to treat psychiatric disorders. Non-pharmacological treatment are going to be things like counseling and psychotherapy, family therapy, psychoeducation, et cetera. Anticipatory guidance is always part of an NP's practice. I don't care if you're a family NP, psych NP, acute care NP, you're always going to be teaching the patients about the healthcare steps that they need to take to ensure their wellness, and that's your anticipatory guidance. And then follow-up is always part, just like you learned as a pre-licensure nurse, as a staff nurse, that discharge planning begins upon admission. Well, at the provider level, follow-up always needs to be part of your plan. When are you going to see them again? What do you need to do next? What will be your next decisions? Okay, so now we're going to do a deep dive into the subjective section. So first comes the chief complaint. The chief complaint is also called the problem identification. This is in the patient's own words as much as possible. There's actually some recent research and debate on this, so don't be surprised if coming down the pike you see that this rule gets changed a little bit. We've always learned and taught that as much as possible, you put the chief complaint in the patient's own words. You keep it to a single phrase. It's acceptable for you to paraphrase somewhat. We've always taught in the past, and we learned as a nurse practitioner myself, and even as a nurse, you learn to use the patient's own words just so it's clear. There's some question that sometimes can this be perceived as insulting or discriminatory towards the patient? If you put it in the patient's own terminology, could that be perceived as mocking their grammar or their speech? So there's some sensitivity around that now. So just be aware of that. But in general, at this point, you can definitely feel comfortable. As long as you're just being honest and being an honest broker, you just want to say why the patient said you're here today. Why are you here today? You want to be narrow. You can expand this in the HPI. So the chief complaint may be vague. So the patient may say, I'm sad, I'm very anxious, or I'm very nervous. My family says I'm very irritable, or I'm not sleeping well. I can't get out of the bed in the morning. As you'll learn as a nurse practitioner, oftentimes this chief complaint can be, for some patients, can be 3 paragraphs long. Some patients will just say, I'm here for a sore throat. Some will kind of tell you their whole history. When you're writing it as a chief complaint, try to just keep the main reason for the visit, really focus on that. And you can always expand this in the history of present illness if you need to. So here's your HPI, your history of present illness. You will learn if you're a primary care nurse practitioner of any sort, a family nurse practitioner, a primary care adult nurse practitioner, et cetera, the old CARTS mnemonic, which is used to do what we call the symptom analysis. So the HPI is your symptom analysis, getting down, give me the details. Okay, so you say you're here for a sore throat, you say you're here for sadness, you say you're here because you're anxious. We need to get some details about that. So old CARTS makes a good sort of template to use. You do modify it a little bit for mental health, but as we show here, so you can say onset, when did this begin? So if they say I'm depressed, when did this begin? And you want to do both all the way back in time, And you also want to do the current symptoms if they've shown up again, if they're having a new episode. So if you're depressed, how long has this happened? Has it been on and off since your teen years, as long as you can remember, or you've always been happy and just over the last 6 months this has started? This is very important information to get. Location, that doesn't really apply to mental health. The duration, this is again where you get the differentiation between a history of a condition and a current episode. So how long has this current one been going on? You've been depressed since your teenage years, you're in your 40s now. Have you been continually depressed, or does your mood go up and down? This is where you really get into the duration, the temporality. The character, if we're talking about pain, physical pain, you say, is it sharp, burning, stabbing? You can apply this to mental health, subjective character as well. Are you depressed? Are you sad? Are you angry? Are you irritable? Are you happy? Are you overjoyed? This gives you a lot of details into these symptoms. Then you want to ask about aggravating factors, just like you would with a physical symptom. What makes your chest pain better or worse? For mental health, what makes your depression better or worse? Does watching a funny movie or being with your family brighten your mood? Does listening to sad songs or thinking about your deceased parents worsen your mood? Get some details, because this is all going to be very, very important. You want to ask about relieving factors. We kind of went through that with the aggravating. So what makes it better, what makes it worse? This is the other side of that. Timing and temporality. We get really kind of confused, and I do this myself when we're going through these time elements of old cards. So you have onset, you have duration, you have timing and temporality. They're each unique. Onset is when it began, absolutely. Duration has been, how long has this been going on? And timing and temporality has been, as it come and go? Is it constant? Does it get better and worse? Is it hard to predict? Is it predictable? And then severity, how is this impacting your life? Are you depressed, but you're muddling through your day? Or are you depressed and you haven't been to work in 3 months? You haven't been out of bed, you're not feeding your family, you're not going to school, etc. So severity is very important as well. So again, the HPI, the old cards, or whatever mnemonic you use, or whatever approach you use, there's the PQRSTU. There's several to use, but remember, this is your symptom analysis, and this is giving you a detailed picture of the chief complaint symptom. And I want to start at this point to start drawing a thread for you that you've probably already experienced in SOAP notes. The SOAP note, each part follows from the other. So right now we're at the very beginning of the subjective section. What we learn in the subjective section is going to drive what we do in the objective section. You can't do everything for all patients at all times. We have to be narrow and we have to be focused, or else we can miss things or we can waste time. So you start with the subjective. The chief complaint starts you off. Why are they here? Why is the patient seeing you today? The HPI goes into a deep dive of that. Let's talk about that. So in the next section of the subjective, now we're getting into history. Now we're fleshing out and getting details that we need to know about the current episode. What may have caused this? What other red flags may exist? In mental health, we do a detailed psychiatric history. You need to get very, very deep into this history. Have they ever been hospitalized for a psychiatric condition? Was this hospitalization voluntary or involuntary? This is a very, very big question to ask. What medications have they been? In mental health, you will get patients that have been on an innumerable number of medications. They may not remember all of them. You have to get as much detail as you can. You really have to spend the time here. What med? Why was it prescribed? If they can't remember the name, can they remember the brand name? Can they remember anything, what it looked like? How many times a day they took it can give you clues. It'll often be vague, but you just really want to get as much detail as you can. Then you want to ask about outpatient therapy. Have they seen a mental health professional on an outpatient basis in the past? Have they had psychotherapy? Have they had medication management? Both? Have they had substance abuse treatment? Inpatient or outpatient substance abuse treatment is very important. How long, when was it? How long ago was it? How long did this treatment last? And why did they stop? Always ask that. Were they feeling better? Did they move? Did they think it wasn't working? Each of these are going to give you important clues into the patient condition. And then, of course, always ask, did it help? That's the biggest question. Did it help? Did you feel better? and now your symptoms are coming back, or did you never really get much out of it? The same goes for psychotherapy. Try to get as much detail. Psychotherapy has specific types, especially on paper. In actuality, what you'll run into is a lot of what we call supportive psychotherapy, which is where someone will sit down with a therapist or counselor and just kind of talk through the problems. Really do a deep dive to see if they got a very standardized, like cognitive behavioral therapy, if they underwent psychoanalysis, something very formal, or if it was more of just a supportive therapy. As part of the psychiatric history, one of the most important parts is suicide. You have to talk about in detail, have they ever had suicidal thoughts? Have they ever had suicidal ideations? These are pretty much synonyms, but you want to differentiate between thoughts or ideations and plans and attempts, okay? So did they ever think about suicide? Have they ever actually planned a suicide? Have they ever attempted a suicide? If they did, how many times have they had each of those, especially if they attempted? How many times have they attempted suicide? When was the most recent? What were the means? You have to evaluate the lethality. Did they try to commit suicide by taking 10 ibuprofen? Or did they try to commit suicide by inflicting a gunshot wound on themselves? This is very important because this is definitely going to help you risk stratify this patient and figure out the best treatment for them. If they did have suicidal ideations or attempts, did they need 911 or the emergency department? Were they hospitalized medically? Were they in the ICU? Is this something they just went to the ER and went home after a few hours? And were they involuntarily hospitalized because of this? All these details are extremely important. And yeah, were they voluntarily? Did they go ahead and voluntarily go into a hospital, or were they held involuntarily because of the suicide attempt? So the psychiatric history can be, when I said earlier that this can be 2 hour-and-a-half sessions, now you can kind of see where we're getting to, because if you're with someone who's a little older and or has a very complex psychiatric history, you can easily spend 45 minutes on this part alone or more, especially if you're doing the due diligence that you need to do. So the past medical history, this is what you're going to be used to if you're a primary care provider. We still do this in psychiatric. We still need to focus on these. You just do it like any other patient. You got to ask about allergies, 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 allergies. You'll hear this throughout your program, whatever your study is. If you don't ask about allergies, you have committed a major neglect, because this is something that can be life-threatening to the patient. Especially if you are prescribing medication and you don't ask about medication allergies. Even if they don't have any, if you don't ask, you're basically, in my mind, you're committing malpractice. I mean, you cannot prescribe a medication without knowing that the patient has allergies. This is your chance to go deep into the medical history and watch for some of these medical mimics of psychiatric conditions. So do they report fatigue, insomnia, either difficulty falling asleep, waking up too soon, waking up during the night? Are they having shortness of breath or palpitations? Of course, we want to rule out medical causes of those. That could be a respiratory or cardiac issue or a circulatory issue, but these will often be a medical mimic of a psychiatric condition. So you want to be very aware of these. This can even extend to digestive issues, chronic constipation, alternating constipation, diarrhea, nausea, vomiting, loss of appetite. These can all be psychiatric issues. Headaches, dizziness, fainting, any perceptual changes. Do they get blurred vision? Do they lose hearing? Again, there can often be a neurological or physical reason for these, but once you've ruled out those neurological, those physical, those medical causes, you may be left with a psychiatric cause. Chronic pain is very important to assess for. In primary care, the vast majority of mental health patients will present with a somatic complaint. So they won't come to you necessarily saying, I'm depressed or I'm sad. They'll say, I'm tired all the time and my body aches. Those are your cues if you're treating these patients in primary care. Yes, rule out the physical causes, but also be thinking of a mental health cause for these symptoms. And of course, any sort of sexual problems. So erectile dysfunction, dyspareunia, loss of libido, any of these can have either a medical and or a psychiatric cause. So that's why you can see you have to do a detailed both psychiatric and past medical history. Past surgical history is always important. You always want to ask about current medications. You want to specify over-the-counter medications, vitamins, minerals, herbals. You really have to ask in that level of detail. All of these medications, herbals, these can interact with psychiatric and other medications, so you need a complete picture of these. Next aspect of the subjective, we're looking at the social history. The social history, we need this in any time that we're assessing a patient, but it is especially important in mental health because a lot of mental health conditions will overlap with what we might consider social conditions. And sometimes the cause, we can't figure out what caused the other. Did a mental health disorder lead to substance abuse, or did high levels of substance abuse lead to depression and other psychiatric conditions? So you have to be prepared to really dig deep and ask very, very personal questions. You have to do it professionally and without embarrassment. You need to do it with empathy and compassion and warmth towards your patient and create an environment of safety and understanding. But you have to ask these questions. You have to ask about drugs, and drugs includes tobacco, it includes caffeine, cannabis, alcohol, prescribed drugs, what we might call street drugs. All these, you have to ask them what they've done currently, what they've done in the past. Have they been treated for this? Was that treatment successful? As we mentioned in the psychiatric history, were they hospitalized? Was it an inpatient, an outpatient, an intensive outpatient program? So there's lots of options here. You got to get down to the marital status. Are they married? Have they been married in the past? How many times? You can, of course, include serious relationships in here as well. Divorced or separated? Are they single? You want to ask about their sexual orientation, sexual preferences. Again, you got to get kind of detailed here because this is all going to come into your case conceptualization and lead to you being able to help the patient and make sure you're meeting their needs. And if you're not asking the questions, they might not tell you, and you might miss something that can have a big impact on them. Sexual activity, their number of lifetime partners, number of current partners, if they've ever been diagnosed with a sexually transmitted infection, are they using pregnancy protection? Of course, in the medical history, you also want to have asked if they have ever been pregnant, currently pregnant, et cetera. That's up there with allergies in terms of a can't miss question. And even we get into the subjective things that you may not think of on a medical side, but you definitely have to ask about their employment. Are they employed? Are they well employed? Are they employed at the level they think that their knowledge level and their abilities meet, or do they feel underemployed? Are they able to pay their bills? Are they homeless? Are they living with others? Histories of abuse and trauma are huge. Did this occur as childhood or as an adult? Is this childhood neglect, physical abuse, sexual abuse, trauma related to military service, first responders, occupational trauma? In this, you need to very carefully ask about histories of head trauma. Patients will underreport this because they may not think it matters if they didn't lose consciousness, if they didn't black out. Even minor traumas can lead to very significant traumatic brain injury, and very mild traumatic brain injuries repeated over time can lead to significant traumatic brain injury. So you really want to ask about that, about sports, motor vehicle accidents, have they been in car wrecks, et cetera. And you got to ask about legal issues. Have they received tickets? Have they been arrested? Have they ever been in jail or prison? Are they currently on probation? Do they currently have cases pending? Are they currently wanted in another jurisdiction? At this point, you can always remind the patient that, especially for an adult patient, we are bound to protect the patient from harming themselves or harming others. Beyond that, everything said to us is confidential. So you really want to make sure that they know that. For children, adolescents, it gets a little sticky, but you always want to kind of maintain that as much as possible. That as long as the patient is not actively harming themselves or others, you're going to lean towards confidentiality. So still continuing with the subjective, we're looking at the family history. Again, just like the medical, you want to do a family psychiatric history specifically. The disorders in their first and second degree relatives, so their parents, their siblings, their grandparents, their children, if they have children. Any history of medications being taken by their family, if they know the medications, at least the class of them. It's very difficult for us to trend and track and predict side effects. The genetic testing that's out there today, it's getting better. It's a little bit oversold, so you really want to be skeptical when someone comes to you and says that this genetic test can absolutely tell you if a patient's going to have side effects. But what we do find is that if they have a close family member that's had negative side effects to a medication, research shows that that actually will be predictive of a poor side effect in the patient themselves. So ask them, mom's depressed, mom always took antidepressants. Mom took Prozac and it just made her feel horrible. It made her feel XYZ. Note that down. Keep it in your conceptualization. Again, for family, you want to check on suicidal ideation, suicidal attempts. If anybody has ever died in the family for suicide, this increases the suicide risk of the patient themselves. Have any family members been hospitalized for mental health concerns? And do the family have any legal issues, especially related to behavior or mental health? And then you want to get the medical history. This is just like your standard primary care interview. And you want to really watch for those mimics. Again, is there a family history of fatigue, a family history of sleeping issues, family history of anger issues or violence? These can all point to a family history of psychiatric conditions that were never diagnosed as such. So now we get to the review of systems. You're going to do your usual medical review of systems depending on the patient's chief complaint. But remember, we talked about those medical mimics. So you do need to ask those general appearance questions. You want to ask about the general questions. Are they having fever, difficulty sleeping, night sweats? Go through all of that. Your heart or respiratory review of systems, skin, weight gain, weight loss, elimination issues, etc. And then you want to add some extra focuses for mental health. So you want to ask about their cognitive. Are they having issues with memory or concentration? You want to ask questions that are related to psychosis. So are they seeing things that or hearing things that aren't there? Are they believing things that other people don't believe? Do they feel that people are after them? That you're looking for hallucinations, delusions, paranoia. You ask them about their mood. Do they often feel sad? Do they feel anxious? Do they feel guilty? Again, here you can also ask about suicidal ideation. I know we're going to hit on asking about suicidal ideation in several places. It's so fundamental to mental health care. Don't worry if it duplicates, and don't worry if you ask it more than once. You want to ask about what we call the neurovegetative symptoms. So are they having issues with their sleep, loss of appetite, or increased appetite, loss or gain of libido, loss of interest, loss of energy levels, etc. You want to ask about anxiety symptoms. So nervousness, fear, panic, fear of open spaces, extreme fear of specific things. So these will be your phobias. Are they terrified to an unreasonable extent of, objects or situations that shouldn't be fearful in and of themselves? Are they having things that may indicate some sort of trauma disorder or PTSD? So are they having flashbacks? Are they having hypervigilance where they're always watching out? Are they having nightmares? You want to ask about nutritional symptoms that may be related to mental health. So are they not eating? Do they binge? Do they throw up after they eat? Do they exercise excessively? Issues related to violence. So do they find themselves very angry, or does their family and friends, coworkers say they're angry? Do they rage? Do they think about hurting people? Do they have a history of assaulting people? And then issues related to impulse control. So do they have uncontrolled gambling? Are there any substance abuse issues? Are they doing things like stealing? That's kleptomania. Trichotillomania is obsessive hair pulling, etc. Okay, so that's our subjective system. There's a lot there. So that's the S of the SOAP. Now we're going to move into the objective section. So we start the objective section with the mental status exam. This is not to be confused with what's called the Folstein mini mental status exam. You may know that from neurology settings, maybe from nursing, or from being a provider in a neurology setting. This isn't that. The MSE, the mental status exam, is the psychiatric form of the physical exam. So if I said, now you're going to perform a physical exam, if you're on the primary care side, or even as a nurse, we've all learned what that means. It means looking at the patient, examining the skin, the hair, the heart, the lungs, the abdomen, etc. The mental status exam is the psychiatric physical exam. Okay, this is what we're looking at. We're looking at appearance and behavior. And remember, we're in objective now. So we're not asking questions to get history. If we're asking questions at this point, it's just to observe the patient's response. So subjective is what the patient tells you, objective is what you observe, and you have to keep those two straight. So appearance and behavior, mood and affect, speech and thought process, thought content and perceptual abnormalities, and sensorial, cognitive, and intellectual functioning. And we're going to go into each of these in detail. So appearance and behavior, you're going to observe this during the interview. Again, I'm going to say it over and over again. This isn't what the patient tells you, that's in the history. This is what you see from the moment your patient walks in the door till they come, they sit down in front of you, and you begin the interview. So how do they walk? Are they shuffling? Are they bounding into the room? Are they slowly kind of moving through? All this gives you insight into their mental status. Their dress. So a lot of these issues in the objective are going to come off as judgmental, and they really are. You're making a judgment. So you have to be aware of that. And not every interesting or different or even bizarre aspect of the patient is going to indicate an issue with psychiatric well-being or an issue with mental health, but it does go into your case conceptualization. So their dress, are they dressed in unmatched clothing? Is it unwashed? Is it wrinkled? Is it radically inappropriate? Is it on wrong? Is the shirt on backwards, or are tags showing, etc.? This all goes into your conceptualization of the patient. Likewise, grooming. Do they smell like they're freshly bathed or showered, or do they not smell like they've been bathed recently? Is the hair messed up? For women, is the makeup put on in a way that doesn't seem like they were able to pay attention to what they were doing? These are all grooming issues. For men, are they shaved? Are they sporadically shaved? Are they unevenly shaved? Now, again, all these can indicate issues of things other than psychiatric. These can indicate issues of housing, of lifestyle, of all sorts of things, or they can indicate no issue at all. So you're not deriving the entire case from these observations, but it's all going into the mix so you can make a good diagnosis. Posture, again, are they standing upright? Are they slumped? Their gestures, are their gestures really wide and energetic? Are they not making any gestures? Are they kind of tucked into themselves? Their facial expressions, are they matching what they're saying? Are they making abnormal or large facial expressions? Eye contact, are they making appropriate eye contact with you? Again, we come into cultural issues, a lot of things going on with this, so it's not an entire diagnosis just based on this, but you need to note it. Did the patient make eye contact with you sporadically? Did they never once look at you in the eye, even when they walked in? Or were they staring you in the eyes the entire interview? These are all important data for you to collect. And then, of course, what we might consider, frankly, abnormal behaviors. Were they very agitated? Dramatic clothing, dramatic cosmetics, intrusive speech. So as you were trying to talk to them, were they constantly breaking in? This is appearance and behavior that helps you form your diagnosis. So mood and affect. These terms get mixed together a lot, and in the textbooks and on paper, there'll be a clear division. In practice, you'll kind of see these mixed together. So don't get too hung up on it. But in general, mood is what the patient tells you. So yes, we're in the objective. That would technically be subjective, but these go together. So if the patient says they're happy, you look at their affect. So do they say, I'm happy, but they clearly look sad or disengaged? That's where the mood and the affect don't match. And that can go for everything. If they say they're depressed, but they're smiling and laughing and joking, don't be fooled by that. Sometimes that can be a defense mechanism or kind of putting on a good appearance. But again, all these things go into your data that you're going to derive your diagnosis from. So you want to look at the quality of the affects, the stability, stable or labile. If they come in and they say they're depressed, they should probably have that same affect through most of the visit. They might perk up towards the end. That's actually what you want. Ideally, as a mental health practitioner, it's great if they feel a little better after they've talked to you when they leave. But if they're all over the place, if they're going from tears to laughing to crying to screaming, that is a labile affect. And that's indicative of what could be a mental health issue. Again, appropriateness, we talked about congruence between the affect and the mood. Range is a term you'll see sometimes in the psychiatric literature. A narrow range means they are pretty flat, and you'll see flat affect described where there's just not a lot going on, or a very wide range, and that's kind of that instability where they're all over the place. And intensity comes in. There's a lot of overlap in these. A flat affect, again, is something that's distant, it's unreactive, while an intense affect means they're really in your face, they're really energetic. So just pay attention to those. And you want to get the congruence between the observed and the reported. That's really the upshot of this. This is the main thing, is what they're telling you and how they're acting matching. Because for most of us, it generally will most of the time. So speech and thought process. So how do these go together? Well, I can't read minds and you can't read minds. So if I want to assess somebody's thought process, I'm doing it by their speech, also by some observing their appearance, but I'm really listening to how they're talking to me. What's the quality? What's the quantity? Are they talking at a normal rate? You know, some of us talk a little faster, some of us talk a little slower. But if they're talking so slow you can barely understand them, or they're talking so rapidly you can't understand them, this is a sign that there may be something going on. Now, disorganization really speaks to that thought process. These are things like loose associations, where they're just making these connections that make no sense at all. Flight of ideas, where they're just going from one subject to the other, almost like a stream of consciousness. So you just can't follow. There's no point. They're jumping from one subject to the next. Circumstantiality, where they're just talking around in round circles. You ask them how they're feeling today, and they start talking about their dog and their kids and what's going on with their car and what they did in high school. And they're just going round and round and not actually addressing simple questions put to them. Tangentials, kind of along this, they start to talk about something and then they just go off on a tangent. Or thought blocking, and this is something you'll see where they start to answer you and they stop. Well, I'm kind of feeling, and then so that can be an indication. Again, a lot of this disorganization, this has to do with psychotic processes like schizophrenia, and in this case, they might be hallucinating voices that are telling them that they can or can't talk. And thought blocking is a good sign of that. So thought content. So before we were talking about thought process, now we're talking about thought content. What's actually in their thoughts, and perceptual abnormalities. These go together. Again, we can't read minds. We can't see what someone else sees. So we have to do it through their speech. This is how humans communicate in addition to nonverbal means. And so we get some ideas of what's going on in their mind. So hallucinations, these can be auditory, and most hallucinations are auditory, less commonly visual, even less commonly tactile or olfactory. People that are seeing or smelling things that aren't there, this should really raise a red flag for a neurological defect of some kind. So that should definitely be, that's kind of a pro tip there, that people are smelling garbage or smelling baked bread or something like that. Definitely that's a good reason to see a neurologist. So hallucinations are things that are being perceived, okay? Delusions are ideas. So these are things like paranoia, like people are after them. And you can ask a patient, are people after you? The interesting thing about all this is you need to get enough good history to know if maybe that's accurate. You know, maybe they're being pursued by the police, or on, you know, on definitely not funny is that they might be being stalked. So definitely get those details. And that's why you do, again, an hour psychiatric history to know the basis for these questions. Now you can kind of see why that detailed history is so important, because otherwise you might not know, is there a rational reason for some of these beliefs, or are they irrational and indicative of a mental health condition? So other delusions are if they feel like they have magical powers, if they have strange ideas. This can be some of the more extremes of conspiratorial thinking, etc. So we have hallucinations, which are things that are being perceived. Delusions are ideas. Obsessions, again, are thoughts. So these are repetitive, distressing thoughts that are happening over and over and over again. Compulsions are repetitive and distressing actions. So we think of obsessive compulsive disorder. You think of the prototypical person that can never leave their house because they have to wash their hands a certain number of times before they can leave. And if they didn't do it the right time, they keep having to go back. They keep having to go back. They can rub their hands raw with washing them. Well, the compulsion is the hand washing. The obsession is whatever thought is going. Usually there's sort of a magical thinking going on that if they don't do something a certain number of times, something horrible will happen to them or to someone they love. So the obsession is the thought, the compulsion is the action. And again, here's suicidal ideation. I told you we would get back to this again. That's an error of thought content. As psychiatric practitioners, in general, we're going to view suicidal ideation as an error of thinking that the patient wishes to end their own life. There's ethical and moral conversations and nuance that can go around that, but you really want to dig deep into suicidal ideation and consider it as something that's abnormal and of concern. So again, you want to ask about hopelessness, worthlessness, guilt. These can be thought content issues that are related to suicidal ideation. Okay, so now we get to sensorial, cognitive, and intellectual functioning. So again, we're in the objective. We're going by the things that we can observe. So good old level of awareness. You know this, ANO times 3 or 4. Can you tell me your name? Can you tell me the date? Can you tell me where you are? And can you tell me why you are here? This is actually the level of awareness. What you're technically measuring is their memory. Do they have sufficient short and long-term memory to know where they are and what they're doing? You can assess their attention and their concentration. Memory, you're getting some memory from orientation, as I just said. There's the 3-object recall for short-term memory. That's where you name 3 objects. You want it to be sort of diverse, so you can say car, apple, chair, and then have them repeat it back to you right then to make sure that they obtained it. And then say, and you can tell them, you're not trying to trick them. Say, I'm going to ask you again in 5 minutes for these questions. Watch your time. I've done many psychiatric interviews. It's very easy, A, for the interviewer to forget to ask in 5 minutes, and B, to forget what you asked. I've done that before. Pick 3, stick with them so that you can remember them, because believe me, we're all human and this definitely happens. Long-term memory can be gauged by past events. Where were you born? Where was your childhood home? Tell me some things where did you go to school? What was your favorite grade, etc. And then general cultural information. This was, who were the last 3 presidents of the United States? You can ask general kind of culturally appropriate questions. Each of these, you can find some criticism in the literature, especially the cultural, because there is a certain cultural bias occurring there. The important thing, as I've hit on again and again, these are all just little clues that are going into your final differential diagnoses list. So know one thing of these, if they don't know who the second to last president was, that doesn't indicate a mental health or intellectual issue necessarily. Maybe they're just a person that doesn't really pay much attention to that. But if they can't, you just need to note it, because added together with other evidence may indicate something is going on that you don't want to miss. Intelligence, generally, there's formal ways of being able to assess this. You can ask them some simple mathematic questions. If they can add 2-digit numbers, that's been associated with an IQ of at least 80. So you can get just a very general intelligence assessment pretty much by your conversation. Same thing with insight and judgment. You can just, if they can tell you why they're there, if they really think something's going on, you can kind of assess their behavior. If they tell you about dangerous things they've done, but they indicate that they weren't dangerous, that kind of shows issues with judgment. So a lot of these, it's subjective in the objective section. I know how frustrating that can be for psychiatric, learning the psychiatric assessment, but you're making a judgment call and you're just trying to be objective as possible about things that the patient is telling you. Okay. So let's recap. We did subjective. These are all the things that the patient is telling you. This is why they came to see you. This is your analysis of that symptom by asking questions and then doing all the history, the medical, the psychiatric, the social, the family, and doing your review of systems, asking all those detailed questions, both for the medical side and the psychiatric side. So you're getting that really deep history of why the patient's there and what has happened to bring them there. Then you went through your objective. In psychiatric, this is the mental status exam. So you went through and you made all those observations of all their different levels of functioning to see if something may be going on and what form of distress may have brought them to you today. Now we're getting into the assessment portion. So assessment, these are your differential diagnosis list or differential diagnoses. You never assess and make a single diagnosis, okay? I can't emphasize this enough. As a healthcare provider, you're not operating as a nurse at this point, as a staff nurse. You're at the level of an advanced practice nurse. You're at the level of a prescribing and diagnosing clinician. So you should always have a list of things that what it might be. You take the subjective and the objective, and from those you make a list of likely diagnoses. You can have a primary diagnosis, and you actually should. That primary diagnosis may be so obvious that it's really the primary diagnosis, but you never, ever only have a primary diagnosis. If you do not have at least 3 diagnoses that you're considering for every patient, you are going to miss something eventually. I cannot emphasize this enough. So again, we take these diagnoses from the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the DSM-5. The DSM-5 is a document created by expert consensus, okay? So think back to all your evidence-based practice courses you've taken, where you've had that pyramid of the levels of evidence. And as you'll recall, expert consensus was generally on the very bottom of that pyramid. So keep that in mind with the DSM-5. DSM-5 is not a magical document. It's in its 5th edition. It changes a lot. It's a guide. It's what you use to get paid by insurance, frankly, but you really got to be careful about applying these labels to patients out of the DSM-5 and thinking that encompasses everything about their mental health. We are complex beings, so you have to be very careful. But at the same time, you need to learn those diagnoses. You need to learn how they are determined, and you need to learn to apply them appropriately. But I just really want you to keep that in mind, that if you're labeling someone as a depressive, as someone with major depressive disorder, that does not encompass everything that's happened to them in their life, in their situation, how they're reacting. So just always be a little bit better than the DSM-5. Again, so these diagnoses, these are based on the subjective and objective elements. As I mentioned before, we're not using a lot in terms of labs, genetics, brain scans to make a diagnosis. So be very clear, we use those in psychiatry as adjuncts, but we don't yet have the blood test that I can look at your blood and say, you have generalized anxiety disorder. We're not there yet. Again, the EEG, the electroencephalogram, there's some pretty exciting work being done in that area. But still, we make our diagnoses by the subjective and the objective elements of the patient interview. So again, here we are again. So before I even get into the other elements of your differential diagnoses, it's suicide assessment. It's always part of it. And we've been through this, but ideations, past and present, plans, vague or specific, lethality of the plans. Are they planning on saying, well, I'm just going to go to sleep and never wake up? Or can they specifically tell you what physical means they're going to use to take their own life? Any past attempts, and if there's the family history of attempts. Again, very, very important. Okay, so now again, we're deriving our diagnoses here. That's what we're doing in the assessment. So the first thing we got to think about is medical mimics. We have to rule out those organic and physical causes first. The reason being, a medical mimic can be a severe life-threatening issue. So if the patient is coming to you and you diagnose them with depression, but they actually have severe hypothyroidism, they have severe anemia, they have uncontrolled diabetes, whatever it could be, a space-occupying lesion of the brain, a brain tumor, you can't miss those. So whether you're primary care, whether you're a family nurse practitioner, psychiatric nurse practitioner, we all have to consider the medical mimics. And this is one reason why it's very important for psychiatric nurse practitioners to at least have this kind of fundamental knowledge that builds upon their registered nursing knowledge, all that general physical knowledge that we learned in nursing school, and kind of apply it to our APRN practice. We can't escape this as psychiatric nurse practitioners. Likewise, family, adult primary care, peds primary care nurse practitioners will benefit from having this mental health standpoint as well. So if you're a purely mental health practitioner, so if you're a psychiatric nurse practitioner, yes, I just said you need to know this, but you're not doing comprehensive physical exams as part of your practice. That's not your practice. That's not what you're being reimbursed for, but you can ensure that they get one. So make sure they go to their primary care provider and get a good, thorough physical exam prior to you settling and locking in on a psychiatric diagnosis. Again, this is for a new patient. So a patient with existing depression that hasn't changed any, you can ask those medical questions. And if nothing new has popped up, yes, they don't need a physical exam every single time, but they should be getting regular physical exams. They should be getting regular primary care to make sure you're not missing one of those medical mimics. You want to carefully assess that history, both the personal and the family. Again, a strong family history of hypothyroidism in your depressed patient should really make you want to dig into that, even if the patient isn't having any, any obvious hypothyroid symptoms, just as an example. Special caution when mental health issues arise brand new late in life. It does happen, but it is extremely rare for someone to all of a sudden develop bipolar disorder in their 40s and 50s. It is very rare for them to all of a sudden develop schizophrenia in their 40s and 50s. Now, what can happen is they could have been undiagnosed for many years, so that is possible. But if a patient comes in and they're behaving in a bipolar manner, so they're having manic episodes, but they've never ever had this in their whole life, and they're in their late 30s, 40s, 50s, you really need to consider a potential neurological or medical reason for that, because it shouldn't, in general, those sorts of issues don't just appear out of nowhere. As further examples, so brand new onset of headaches, brand new onset of perceptual issues, functional issues, they suddenly can't get around the house, they suddenly can't take care of themselves. You really want to look for a non-psychiatric source of those. And you're always looking for issues that could be drugs, alcohol, all those things we covered in the history section that might end up being on your differential diagnosis list. Okay, so again, we're in the assessment section, we're in differential diagnosis. So we can take our example. So we have a patient coming to us for depression, for sadness. And so you want to evaluate them. And on your differential diagnosis list, which if they meet criteria, major depressive disorder, MDD, might be their number one diagnosis. But if they mention that they've had some skin or hair changes, then, or they've had fatigue, then hypothyroidism might be on your differential list. Anemia might be on the differential list. So you might order some labs or send them to primary care to get these labs to rule those out before you just move forward with your depression diagnosis. If you miss one of those physical medical issues, you can cause severe patient harm. So look in your textbook, box 17.9 for the Think Med mnemonic. There's boxes 17.6, 7, and 8 go through medical mimics of specific disorders. I won't just rattle them off here. Read up on those, very, very important, whether or not you are a psychiatric or a non-psychiatric provider. Okay, so now we're going to start actually getting into the psychiatric differential diagnoses. DSM-5, ICD-10, we've covered that. So here's some DSM-5 categories. They're the anxiety disorders, mood disorders, substance-related disorders, eating disorders, thought disorders, trauma and stressor disorders, and medically unexplained symptoms. And we're going to go into a little bit of detail for each of these. So for anxiety, you have panic disorder. This is a disorder characterized by panic attacks, as well as the fear of panic attacks. And there's specific criteria that you can read in the DSM-5. There's generalized anxiety disorder, which is a chronic, formless, vague anxiety that doesn't have a clear source. Agoraphobia, which is a fear of either crowds or open spaces. A specific, what we call specific phobia, so people that have an unreasoning fear of a specific object or animal or situation that is negatively impacting their life. Social anxiety disorder, fear of public speaking or being in public, or separation anxiety disorder. This is a specific pediatric disorder. So all of these are the definition of a psychiatric diagnosis, just to go back, is it has to be causing either significant distress or negatively impacting their day-to-day living. So your mood disorders, you have major depressive disorder. This is a depressed mood or loss of interest over a 2-week period, plus 5 or 9 of the specific list of criteria. SIGI CAPS is a mnemonic worth memorizing. So whether or not you're psychiatric or non-psychiatric provider, it's definitely worth memorizing it. Spend a little time. So your sleep, interest, guilt or worthlessness, energy levels, concentration, appetite or weight change, and psychomotor agitation or retardation. So psychomotor agitation is when people, they'll be depressed, but they'll feel like they just can't sit still. Or psychomotor retardation just means they don't feel, they have no energy. They feel like they're moving slowly. They feel like they're just swimming through syrup all the time. Also in the mood disorders are the bipolar disorders. So bipolar 1 is defined by the manic episode. It's not defined by the depressive episode. So bipolar disorder is a manic episode, at least one, that lasts at least 1 week or results in hospitalization. So if your patient had a manic episode where they were distractible, they were impulsive, they were not sleeping for several days, and it only lasted 3 days, but their behavior was so bizarre that they ended up in a mental hospital, a psychiatric hospital, then that counts as a manic episode. So they have to have at least 3 of those symptoms, which the dig fast mnemonic is very helpful. So distractibility, insomnia with a decreased need for sleep, grandiosity, where they just feel like they're the king of the world, flight of ideas, where they'll say my brain was just going a million miles a minute. I couldn't stop all the ideas I was getting. Increased activity, so they're just bouncing off the walls. Pressured speech, they're hyperverbal, they're rapid, they just can't stop talking. You will know a manic patient when you encounter them. You may talk to people that kind of say in a colloquial manner that they're a little bit bipolar, they're a little bit manic. When you deal with a patient in a true manic phase, you will know it, and it's unmistakable. Bipolar 2 is actually defined by depression. So this is depressive episodes mixed with hypomania. Hypomania is less severe than mania. It's mainly just so this would be periods of depression with periods of very elevated mood that don't quite meet the criteria of a true mania. And then there's some associated mood disorders. There's cyclothymic disorder, which is kind of that same up and down, but doesn't meet the criteria for bipolar 1 or 2. Seasonal affective disorder, that's the older term. It's now a seasonal modifier for the mood disorders, but this is depression, any of the mood disorders that's modified by the time of year, especially the winter, the dark months. This actually this has to do with the neurology of the brain. Postpartum mood disorders, so postpartum depression, postpartum psychosis, or postpartum mania. This occurs after childbirth. And then premenstrual, what used to be called premenstrual dysphoric disorder. These are disorders occurring around the luteal phase of the menstrual cycle. I won't go into a ton of detail of these. We're getting a little niche. You can absolutely feel free to read up on these and know about them. They're definitely something you may encounter in primary care, and you absolutely will encounter these in mental health care. Then we have the substance-related disorders. The DSM-5 now calls these substance use disorders. There's now a separate diagnosis for each type. So in the DSM-4, and previously it used to just be an umbrella term. Now there is opioid use disorder, alcohol use disorder, tobacco use disorder, et cetera. Each type can be divided into mild, moderate, and severe. This is very, very commonly comorbid with psychiatric diagnosis. And I mentioned it earlier, it becomes a chicken and the egg issue. Did they have an undiagnosed or untreated psychiatric disorder that led towards self-medication via substance use? So taking drugs or drinking alcohol to try to calm whatever the mood disorder is? Or have they used substance uses to such an extent that now they're having manic episodes, they're having depression, et cetera? It can be hard to tease out. You need to try. Do try. You almost always want to treat substance use and psychiatric issues concurrently as much as possible. You always want to treat substance use almost always. There's always an exception, but you got to get those treated. You're not going to make a lot of progress on the psychiatric issues if you don't. Substance use can mimic psychiatric symptoms. So someone that's coming to you with, say, delusions or paranoia or hallucinations, that can be the result of methamphetamine use or Adderall abuse, things like that. So you have to be aware. You have to find out if there's a substance on board. And the other way too, if the patient, you think, oh, this patient might be drunk on alcohol or they're on methamphetamine, and it turns out that they're not on anything at all, and that's actually an expression of their psychiatric disorder. Eating disorders. This is something that will commonly be encountered in primary care, and it is a very, very highly deadly group of disorders. You have to be really careful. Anorexia especially can be severely life-threatening. These patients go into such severe electrolyte loss that they will have cardiac arrest and die. So you really have to watch these patients. They are very, very challenging to treat. It often takes a team approach. It takes a lot of empathy and compassion. These are very challenging conditions to treat, and they're very, as I said, very highly lethal. So you really want to be very, very conscious conscious of these patients. Anorexia nervosa, less than 85% of what could be considered normal weight. It's usually a reduction in intake. Purging can be present. So if a patient is purging, that doesn't automatically mean bulimia nervosa, which we'll get to in a second, especially so if they're underweight, very low BMI, and if they're purging, that's anorexia nervosa with purging. In women, you're going to very often see amenorrhea or irregular menses. It's not required for diagnosis. It used to be, but it's not anymore. Bulimia nervosa, this is binging and purging at least once a week. The binging is uncontrolled. So they feel like when they get in front of food, they physically cannot stop themselves. Binging is defined as a concentrated episode of overeating to the point of discomfort, and again, with the lack of control. In these patients, you want to look for dental changes, so caries or cavities, enamel loss, chipped teeth from physically using objects to help them elicit the gag reflex and vomit. You want to look for callus on the dorsal aspect of the hand, again, from putting the finger down the throat to induce vomiting. Binge eating disorder, so this is the binging without the purging aspect, minimum of at least once a week for the last 3 months. These patients will generally be overweight. They will be very distressed and ashamed by their binging behavior. That will be that same uncontrolled, large intake of food to the point of discomfort. And as I said, you got a lot of high morbidity and mortality across all the eating disorders. So whatever setting you're in, really have your eye out for these. So the thought disorders, these can be disorders of thought content. So they can have an inaccurate assessment of reality. We discussed this previously. Delusions are false beliefs. So delusions of persecution, grandeur, somatic delusions, so feeling that there's something implanted in their body, paranoia, feeling people are after them, magical thinking that they have magical powers of some sort. It can be involve the thought form. So again, the loose, the circumstantial, the tangential. Neologisms means they're just making words up and inserting them into conversation. Word salad is where just a bunch of words are being mixed together with no rhyme or reason. Clang is people that have speech that is characterized by the sound. So they might say tang, wang, bang, gang, bang. So the meaning is absent, it's more the sounds. These are seen in the psychotic disorders, especially schizophrenia. Perceptual thought disorders are your hallucinations, so you're perceiving or sensing things that are not there. Illusions are different from hallucinations. So an illusion is misinterpreting something that really is there. So hallucinations, if they just look at a blank wall and they see a person, that's a hallucination. If they look at a standing lamp and they see a person, that's an illusion. That's misinterpreting something that is really there. So these thought disorders can be a result, of course, of psychiatric illness. They can be the result of drugs or medications, and they can be the result of organic illness. So they can be a result of a brain disease, of an infection, of a space-occupying lesion, of an electrolyte abnormality, et cetera. So again, with the thought disorders, our prototypical is schizophrenia. They have 2 or more of delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, or negative symptoms. We haven't really talked about the negative symptoms yet. These are things like flat affect, poverty of speech, avolition, meaning these are people that just won't do anything unless you physically move them and have them do it. Anhedonia means they just take pleasure from nothing. And social isolation is a negative symptom as well. They don't talk to people. They don't want to talk to people, very isolated. Again, that in and of itself is obviously not diagnostic of schizophrenia. None of these are, but taken as a whole. And that's what we're going over and over again with psychiatric diagnoses. You have to take every element together, and that's what gives you your diagnosis. There's subtypes of schizophrenia. There's the paranoid, disorganized, catatonic, where there's no movement, no reaction. Undifferentiated just means it doesn't fit into the other categories. Residual means that there's been a recovery process, but they still have some of those symptoms. Your differential diagnosis for schizophrenia are things like schizophreniform disorder, which is a short, brief schizophrenia-like disorder, schizoaffective disorder, which is schizophrenia mixed with a mood disorder like depression or bipolar, delusional disorder, where the only symptom present are those ideas, those abnormal ideas, brief psychotic disorder, so this is a very brief psychotic episode, and then the substance-induced psychotic disorder. Look at box 17.6 in your text for organic causes of delirium and psychosis, and that'll be helpful to kind of give you an idea, again, of those medical mimics, those organic causes that we always have to look out for. Okay, so the next category is the trauma and stressor disorders. Here we have acute stress disorder. This can last 3 days to 1 month after exposure to an experienced or witnessed traumatic event. Traumatic events are extremely frightening events that place the patient in either threat of their own personal life or wellness or observed in others. So it can be direct or indirect. Adjustment disorder is a shortened disorder where they have these symptoms, and this is within 3 months of exposure to the trauma, and it resolves within 6 months of the stressor ending. Reactive attachment disorder is a pediatric trauma disorder. There's the inhibited and disinhibited types. These are symptoms, they have to be evident starting in children between 9 months and 5 years. It's the result of either neglect or deprivation during that developmental period. And you have to rule out autism spectrum disorder. So this is not related to autism. Inhibited reactive attachment disorders are where the children just won't bond with any form of caregiver. This is always defined as an appropriate caregiver. So obviously, not wanting to bond with an abusive caregiver is not irrational. But so in a caring, supportive setting, if these children just cannot attach, that is the inhibited type. Disinhibited type are the kids that have had this sort of experience and they'll just run around with anybody. They'll run with the stranger down the street. They don't have that sort of normal level of inhibition that any child should have. So it can go to either extreme, and different children will react in different ways. And of course, the prototypical trauma stressor disorder is PTSD, post-traumatic stress disorder. This is a disturbance in relation to a trauma that lasts longer than 1 month. And they have to have symptoms from 4 symptom clusters. So you have the intrusion cluster, and these are things like memories, dreams, flashbacks, or psychological or physiological reaction to triggers. So a reminder of the trauma comes up and they either feel that intense fear or they feel the heart beating, the skin, clammy skin, etc. They need at least one from the avoidance cluster. This is either trying to avoid the memories, thoughts, or feelings of the traumatic event or avoiding any external reminders of the traumatic event. The next cluster is negative alterations in mood or cognitions. They need at least 2 of amnesia, so they just don't remember, can't remember. Negative beliefs about the event, including self-blame, so blaming themselves for it. Negative emotions, just having that anger or sadness consistently. Decreased interest, detachment from the world. Again, there's that anhedonia, so an inability to derive pleasure from previously pleasurable activities. And then the last of the symptom clusters is arousal. They need at least 2. So this is the irritability or anger. Recklessness is a symptom of PTSD. Hypervigilance, again, that's that always being on guard. An enhanced startle response. So these are the people, I studied at the VA for part of my psychiatric training. So of course I treated lots of veterans with PTSD, and at 4th of July, they would often just be miserable and we would always see them. I trained over a couple of summers and you would see them the week after 4th of July where they just had to hide in their house because those fireworks and the firecrackers were really setting off their PTSD. So that's that startle. And then also difficulties with concentration or sleep issues are part of that arousal cluster. Medically unexplained symptoms is kind of your last diagnostic category. There used to be what we call hypochondriasis, hypochondria, sort of a exaggerated fear of medical illness. That's been eliminated in the DSM-5. It's been replaced by either illness, anxiety disorder. So this is the patient that's not having any somatic symptoms whatsoever. They're not feeling anything, but they fear that they have a certain illness, or somatic symptom disorder, where they're having some sort of vague somatic symptom. Often these have been medically ruled out. So they're kind of having a chronic stomach issue or a chronic muscle pain. No medical issue has been found, but they're having those somatic symptoms along with a out of proportion distress related to it. So they're very obsessed with the idea that they may have a serious illness, even after that's been ruled out. And pain disorder is now considered a subtype of that somatic symptom disorder. Factitious disorder, this is where, with the hypochondriasis, the former diagnoses, so the illness anxiety disorders, those the patient isn't purposefully making something up. They really believe and really fear they have those disorders. They really feel those somatic symptoms. With the factitious disorders, they are lying. They are making this up. They're either making it up about themselves, or they're making up about someone else, so a family member, a child. This is something that used to be called factitious disorder by proxy. Even prior to that was always called Munchausen's by proxy. So Munchausen's disorder was a disorder of false claims of illness, and Munchausen's by proxy was a false claim of illness in another person, often a child or an elderly parent. And this is where the patient is seeking a form of attention from either their own illness or from someone else. So that's how you kind of tell the difference between those two, whether it's purposeful or the patient themselves is unaware of it. Whew. Okay, we're doing good. So we went through, let's recap once again. We went through this objective, why the patient is here, a detailed examination of that reason they gave, then all the history and review of systems to kind of get some historical information about the patient's condition. The objective, the psychiatric objective is done through the mental status exam. We do a detailed interview to get the information that we need to form a judgment of how the patient is functioning and what they may be experiencing, basically what's going on in their mind, since we can't read their minds. That, the subjective and the objective, led to our assessment, which is our differential diagnosis list. We took all the things that we learned in the subjective and the objective, and we came up with a list of differential diagnoses. Hopefully we have a primary diagnosis. We might have some medical mimics on that list. Now we're to the plan section where we decide what we do. In this section, we're going to stay kind of brief because for purposes of this talk, we're really focused on how we derive that differential diagnosis. And that differential diagnosis list is coming from our subjective and objective. But we're going to cover this briefly. So the plan is going to consist of some diagnostic testing. It might be drug levels for psychiatric medications to monitor those effects. It might be medical labs to rule out mimics. So it might be blood levels to look for anemia. It might be thyroid levels to look for thyroid disorder, a metabolic panel to look for electrolyte disorders or diabetes, etc. We'll come up with a pharmacological treatment plan. So each of these diagnoses we went through have their own pharmacological treatments that you will come across in your pharmacology courses. If you're a non-psychiatric NP student, you'll learn some psychopharmacology. And of course, if you're a psych NP student, you'll be learning general pharmacology as an APRN student. And then we'll be doing a deep dive into psychopharmacology. So we're going to get plenty of that, don't worry. You're going to form the non-pharmacological treatment plan. So this can be psychotherapy, family therapy, social work. This might be housing assistance. This may mean arranging a meeting with their clergy person if they're very religious. So there's going to be non-pharmacological aspects, anticipatory guidance. So this is going to be health promotion behaviors. This is going to be things like tobacco cessation, regular testing per guidelines, so things like your mammograms and colonoscopies, safety behaviors, seatbelt wearing, etc. And then you're going to determine your follow-up. So when do you want to see them again? Do you need to see them in a week, in a month? Are they going to get some testing and then come back to see you? If you are a primary care provider, are you going to send them to a mental health provider for further evaluation? And you always want to include emergency precautions. This is going to be a part of your plan no matter where you're practicing. In the psychiatric mental health terms, it's going to be primarily, again, suicide precautions, when to call 911, give them the suicide hotline, when to go to the ER. But also, if they came to you with psychiatric symptoms, but you're still worried about medical mimic, if they just develop a very severe headache, changes in their levels of consciousness, if they start having hallucinations when they did not have them before, etc. You want to go very, very detailed into those emergency precautions. There's a lot more that goes into planning, and that will come at different portions of your NP education. Okay, so let's wrap up. Let's conclude. The process of deriving a differential diagnosis is pretty much common across all domains of healthcare. So again, whether you are a family NP, a psych NP, a PEDS primary care NP, a PEDS acute care NP, a neonatal NP, an adult NP, etc., you derive a differential diagnosis list by taking the subjective elements and the objective elements, using those to make a logical and rational list of what may be going on with the patient. In particular, the psychiatric differential diagnosis is driven almost entirely by history and observation, meaning there's not a physical exam element. Usually you're not listening to heart and lungs, you're not palpating anything, and not a lot of labs. You're not running a blood test to diagnose anxiety. You're not going to diagnose schizophrenia with an X-ray. Mental health complaints are common in all health settings. So even if you are a non-psychiatric NP student, you're going to come across these complaints. They're going to come across no matter where you're. So if you're practicing if you're a student or you're a practicing NP, in whatever setting, you're going to have patients with mental health conditions and complaints come across. So these skills will be very useful. Likewise, the psychiatric interview techniques can benefit all specialties. I was a family nurse practitioner before I became a psychiatric nurse practitioner. And in addition to some other benefits, my practice as a family nurse practitioner and eventually as an emergency nurse practitioner was enhanced by my enhanced ability to perform a good interview. So these skills will benefit you whatever setting you're in. Beware of medical mimics, and that's going to be tied to the next one. Always think worst first. This is my bias from being an emergency nurse practitioner certified for many years in the ER. You always want to rule out, is this something that is going to severely harm and or kill my patient in a short period of time? Do I need to rule out a heart attack, a stroke, a brain tumor, a severe hyperthyroid condition, a thyroid storm, a severe diabetic condition, like a severe hypo or hyperglycemia, et cetera? Think worst first, think medical mimics, because often, with the exception of suicide, which is probably our most life-threatening thing that we encounter in mental health, most of the mental health diagnoses are not going to be an immediate threat to the patient's life. They're going to be a threat to their well-being. So we want to treat them, but we definitely want to treat those life-threatening conditions first. And most of all, always maintain compassion, both for your patient and for yourself and for your fellow clinicians. You know, psychiatric patients can be extremely challenging, and they can challenge us on a very deep level. I mean, I think I'll have another talk to do about the concepts of transference and countertransference that we see in psychiatric mental health practice. They can be very, very challenging, and it can be easy to say to have compassion. And these are people that can be acting bizarrely, they can be acting rudely, they can be acting aggressively or threateningly. And you just have to remember, psychiatric illness is illness. So just like we maintain compassion for our diabetic patients, for our patients with cardiac disease, we need to have compassion for our schizophrenic or bipolar patients, our PTSD patients. They're all suffering, and we're here to treat that suffering. At the same time, have compassion for yourself. If you're having these reactions, that's normal. There's nothing wrong with you. If an angry patient makes you frightened or angry in response, that's okay. That's natural. You need to set that aside, assuming that you maintain your own safety, which always comes first. But you do have to kind of set that aside to treat the patient, but don't dismiss it. Don't be afraid to seek care or support or mentorship, because we are human beings, and it's natural for us to have those reactions. And likewise for your fellow clinicians. If you're a mental health clinician or even a non-mental health clinician, and maybe you don't agree with the plans of care or how other clinicians are approaching mental health patients, remember that they kind of can suffer from that same level of compassion fatigue. So we just want to be kind of generous with our thoughts for all of our patients, and especially for ourselves. So I thank you very much. I know that was intense. It was deep. There was a lot of information there. I tried to pare it down just to the things that I thought were very, very necessary. It may bear listening to and watching again. It may bear watching in pieces, so you're not trying to make it through the whole lecture. But I hope you found it useful. I hope you found it helpful. Please always feel free to reach out with me for any questions, corrections, comments. I'm always here. I'm here to learn, and I'm here to support your learning. So best of luck. Take good care of yourselves. Take good care of our patients, and be good out there.